Okay, let's set the scene for you. A patient is rushed into the emergency department. They're really struggling for breath acute dyspnea.
Right.
And the doctors right there, they face this fundamental puzzle. Are you short of breath because your heart is failing, what they call ADHF? Or is it a severe lung infection, pneumonia?
And that is such a common high-pressure dilemma because those two conditions, they can look almost identical at first glance.
So the instinct is.
The instinct, when you can't be sure, is to start intravenous antibiotics. It's a just-in-case move. Cover your bases.
But that's exactly what we're diving into today. The huge, often just ignored, unintended consequences of that just-in-case decision.
Specifically for heart failure patients.
Exactly. Our mission here is to synthesize the clinical research, look at the pharma data, and show you this hidden sodium and fluid load that's literally piggybacking on these IV antibiotics. And we'll show how it can completely sabotage treatment.
Yeah, this goes way beyond the usual antibiotic stewardship conversation, which, is almost always about resistance. This is about direct patient harm. Harm from the carrier fluid, from the salt and the drugs formula. If your main problem is too much fluid, and your medicine adds liters of fluid and grams of salt, well, that's a critical misstep.
So let's start at the beginning with that initial confusion. Why do ADHF and pneumonia look so much like twins in the ER?
Well, both cause that severe shortness of breath. You can hear crackles in the lungs with both conditions. The patient just looks critically ill.
Right.
And telling a difference between, fluid overload and infection in those first few hours, it's a real challenge for any clinician.
And because of that, giving both treatments is surprisingly common.
It is. One big study we looked at found that about 29% of patients admitted for heart failure ended up getting antibiotics.
But the really eye-opening data, I think, came from a study that specifically filtered for patients who were later confirmed to have a low risk of infection.
Yes, and they were really careful about how they define low risk. They kicked out anyone whose chest x-ray even hinted at pneumonia, or if a key blood marker for infection, procalcitonin, was high.
So the tests are basically screaming no infection here.
Exactly. And yet, even in that low-risk group, a shocking 39% of those heart failure patients were still started on IV antibiotics.
39%. Why? If the objective data says no, what's driving that decision?
It seems to come down to how sick the patient looks at presentation.
So just the general severity.
That's what the data suggests. The study found the group that got the antibiotics, they had slightly higher Apache 2 scores. It was 10.1 versus 8.1.
Now, the Apache 2 score, for our listeners, that's just a system for grading how sick a patient is, right?
Correct. And while 10.1 versus 8.1 might not sound like a huge gap, in a busy ER, that small difference means the patient seems a little sicker. Maybe their blood pressure is a bit lower, their oxygen is a bit more off.
So that feeling, that subjective assessment that this person is sicker, it's enough to override the negative lab tests and start the antibiotics.
Dreadfully. And that's where this hidden salt and water tax comes into play.
Let's get into the mechanics of that tax. Because for a heart failure patient, the harm is immediate. Where is all this salt and fluid coming from?
It's really a 1-2 punch. First, the antibiotic itself can be a sodium salt. That's just part of its chemical structure for stability.
Okay.
And second, these drugs are powders. They have to be mixed with a liquid to be infused, and the go-to liquid is almost always normal saline.
Which is basically salt water.
It's a 0.9% salt solution. So you're adding salt from the drug and salt from the bag it's mixed in.
For a patient who is supposed to be on a strict fluid limit, maybe getting diuretics to remove water, you're pouring water back in?
You're prescribing the cure and the disease at the same time. It completely undermines the entire treatment strategy. We're trying to keep them under, say, 2 grams of sodium a day, and the sources show that the IV antibiotics alone can blow right past that limit.
This is where the numbers get genuinely wild. Let's quantify this tax. These are some of the daily sodium loads we found in the data, and this includes the standard diluent fluid.
Let's start with a classic, penicillin G sodium. A typical daily dose of that can deliver, get ready for this, about 3,229 milligrams of sodium.
Wait. 3.2 grams.
Yes.
To put that into perspective for you, the recommended daily limit for a healthy person is 2,300 milligrams. For sick heart failure patient, it's closer to 2,000. So one antibiotic given just in case obliterates their entire daily budget.
And that might be continued for 2 days while waiting on cultures. That's over 6 grams of unnecessary sodium pumped directly into their veins.
And it's not just penicillin. Ampicillin can be up to 2,926 milligrams a day.
Oxacillin is always high, somewhere between about 2,800 and 3,000 milligrams.
Even newer drugs, like linezolid, if it's mixed in normal saline, you're still looking at around 2,355 milligrams a day.
And one of the most common hospital antibiotics, piperacillin tazobactam. Even a standard dose of that can pack in 1,700 to almost 2,000 milligrams of sodium. That's their entire daily allowance just for the antibiotic.
So how does this slip through the cracks? I mean, these are sophisticated hospitals. Why isn't there a big red flag that pops up saying, warning, high sodium drug for a heart failure patient?
That's the core systems problem, you know. The doctor prescribing is focused on killing the bug. The pharmacist is focused on safely preparing the dose. But unless there's a really proactive stewardship program, the sodium and fluid content just isn't front and center. It's a disconnect.
And we have to keep saying it. It's not just the salt. It's the salt dissolved in a significant amount of fluid, which is the last thing that patient's heart needs.
Exactly. So now we have to ask, did this hidden tax actually cause measurable harm?
And the answer from the research is an unambiguous yes. Let's dig into that core study of the 144 low-risk heart failure patients. The differences are just stark.
They are. The patients who got those unnecessary IV antibiotics received, on average, an extra 1.7 liters of fluid.
Almost half a gallon.
And over 9,300 milligrams of extra sodium during their stay, all from the antibiotic therapy alone.
That is a massive fluid challenge for a struggling heart. And you see the consequences directly in the primary outcome, right? Length of stay.
Absolutely. The antibiotic group had an average hospital stay of 6.6 days, the group that didn't get them. Just 3.0 days.
So their hospital stay more than doubled?
It more than doubled. And that extra time in the hospital wasn't just waiting around. It was because they needed more intense treatment.
To deal with the extra fluid.
Exactly.
Yeah.
The patients in the antibiotic group needed almost 3 times more furosemide. That's the main diuretic, to try and get rid of all that extra fluid.
We're talking 930 milligrams versus 320. So you're forced to use triplet firepower just to undo the damage from the just-in-case medicine.
And that puts so much stress on the kidneys, it creates all new risks.
And the harm follows them home. The study found those patients were 2.51 times more likely to be readmitted to the hospital.
That readmission risk is the ultimate sign of a bad outcome, and it all traces back to an antibiotic that wasn't indicated.
And this wasn't just a fluke in one study. Another one from a totally different health system found the same thing.
Yep. Longer stay 5 days versus 3 or 4. And they tracked the total sodium, too. The antibiotic group got a median of 9.22 grams of sodium. The other group, 0.28 grams. It's just a huge difference.
So the data is clear. It's not a harmless choice. It actively makes the patient sicker, keeps them in the hospital longer, and makes it way more likely they'll be right back.
And if the sodium and fluid risk isn't enough, we also have to remember that IVs open the door to a whole bunch of other electrolyte problems.
Okay, so let's broaden this out a bit. It's not just about volume overload. What other traps are hidden in IV antimicrobials?
Well, many of them mess with the kidney's ability to manage other electrolytes. A classic example is the aminoglycosides. They can cause low potassium, low magnesium, and low calcium.
And for a heart patient, that is incredibly dangerous.
Oh, absolutely. Those shifts can trigger cardiac arrhythmias. It can get really serious.
What about some of the others? Antifungals have a bad reputation.
They do. Amphotericin B is famous for it. It can cause hypokalemia low potassium in up to 90% of patients. It also drops magnesium levels. It basically makes the kidney cells leaky.
And then there's that very common antibiotic, trimethoprim sulfamethoxazole, TMPS-MX.
Ah, that one's different. It doesn't cause volume issues, but it can cause high potassium hyperkalemia.
How does it do that?
The trimethoprim part is actually structurally similar to a potassium-sparing diuretic. So it acts like one, telling the kidneys to hold on to potassium, which can lead to dangerously high levels, especially in someone with kidney problems already.
So when you stack all this evidence up, it really reframes what antibiotic stewardship is all about. It's not some abstract goal to prevent resistance down the line.
No, it's an immediate patient safety mandate. It's about preventing direct, measurable harm from the medicine's formulation and its delivery vehicle.
Which means we have to be thinking about getting off IVs as soon as possible.
That is the actionable insight. Stewardship programs have to push for the earliest appropriate switch from IV to oral antibiotics. That simple move can dramatically cut the patient's exposure to all this extra fluid, sodium, and the other electrolyte risks.
So to bring this all home for you, in these volume-sensitive patients, we absolutely cannot treat the delivery system as if it's inert. The diluent, the salt formulation, it all matters.
It does. And the sources prove that what seems like a small precautionary step ends up being clinically detrimental. It prolongs recovery, it triples the need for other drugs, and it sends the patient out the door with a 2.5 times higher risk of coming right back.
And understanding this helps you see the whole domino effect. A reflex action to treat shortness of breath creates a new problem volume overload that needs way more aggressive treatment, leading to a longer, more expensive, and less successful hospital stay.
So think about this. We're all told to keep our sodium intake under 2,300 milligrams a day. If one common IV antibiotic can dump over 3,000 milligrams of sodium into a patient in a single day, a patient who is already drowning in fluid, what does that say about the blind spots in our system? It's a subtle danger, but it's hidden in plain sight, and it requires our sharpest attention.